Hello, my name is Victoria Batchelor, and on behalf of SBK Healthcare, I'm delighted to welcome you to the recording of this webinar on Emergency Department Streamlining Your Front Door Admissions. This webinar will give you the opportunity to discover practical guidance on overcoming A&E admission challenges and how to incorporate a get it right first time approach into your service. This webinar has been designed for NHS professionals working in emergency departments, and you will benefit from hearing the first-hand experience of Stevan Bruijns, a consultant in emergency medicine and a specialty advisor for NHSE Southwest Urgent Care Team, as well as the CQC's Urgent Care Team. Make sure you check out our website for our other webinar content, and also we run in-person conferences and other online training for which the details can also be found on our website at www.sbk-healthcare.co.uk. Thank you, and I hope you find this webinar informative and enjoyable.
Okay, thanks. So thanks for that, Victoria. My name is Stevan Bruijns. I'm a consultant in emergency medicine. I work with Somerset NHS Foundation Trust. I also have been dabbling with some improvement work over the last 2.5 years with Southwest team. And I also inspect for the CQC. Before that, and this contributes to specifically how I'm going to do my presentation, hopefully giving you something a little bit different. I've worked extensively in global health. I was the chief editor for the African Journal of Emergency Medicine, and I worked for my PhD. I did some work in trauma research, and this was largely based around data translation. And so all of this work, which I've done up until now in my career, spanning around 24 years, have kind of come together in the work which I'm currently doing in terms of improvement with NHSE and the Southwest, and also with the CQC. And a lot of what I'm going to be talking about here today is work which I have presented in other forums. And so some of the slides, if you've been in forums where I have spoken to, you would recognize some of these slides. Now, you don't need to take pictures or anything of the slides. We're going to send you the slides afterwards, so it's nothing to worry about that. So you can just sit back and relax. If you've got any questions, my recommendation is that you just pop it in the Q&A, and then we can get back to that towards the end of this presentation. Otherwise, you might forget what your question is. All right. So I've been asked to talk about streamlining at the front door. And I'm going to start off by just kind of defining how we should be looking at the front door, or at least the way that I am looking at the front door. So I know I've seen the attendee list. I know there's a lot of you guys who are from nursing background, from clinical backgrounds spreading across emergency medicine, acute medicine in the community, and then also our operational team sitting in ICBs and acute trust. So this is quite an eclectic bunch that we have brought together because we all have a different view of urgent and emergency care, and all of our views are valid. It's just because we are looking at the same problem from different angles, we sometimes have a very different way in which we interpret that view. So I'm going to try and define the way that I see it. So the simplest way for us to think about urgent and emergency care is to start where all the data is. So since 2004, when the whole 4-hour target thing came into emergency medicine, the whole system was kind of set up to start collecting data. So we have an understanding about how the 4 hours are meant to be achieved. And we've added all these metrics. It culminated in the ECDS in the early 2010s being set up, so we can have this whole wealth of data about what is happening in our emergency departments. As the wheels kind of started coming off, what was going on in emergency departments, we started to kind of spread that information. We went to look at, our ambulances and what they are doing. And then later on, much later on, more recently, we started to look at what is going on inside our hospital. But essentially, there are these 4 areas in the hospital: patients waiting to leave our departments, patients waiting to come into our emergency departments, and the community. And this kind of defines urgent and emergency care, the areas where we are working when we're talking about emergency care. Now, for me as a clinician, this is probably really important to know because I deal with patients, and obviously we exist for our patients. We want to provide a service to them, and we want to have them give them a safe service, but also we want to give them a good experience coming through the service. So enter the 4 harms. The 4 harms is not my idea. It's Dr. Ben Owens came up with this. So Ben Owens, who works for ECIST, and he's with Sherwood Acute Trust, defined the 4 harms. And what Ben said is that there are 4 distinct areas which we can see harm occurring when there are delays. So the first one I've already said is patients that are not flowing through our hospitals when they should be. So deconditioning is a massive problem. So patients leave in a worse state that they come in for the simple reason that they have stayed too long. We have got harm, and actually there's a number that we can attach to this, thanks to some research which was done by the Royal College of Emergency Medicine, but these are for patients that are not exiting our emergency departments in a timely way to admissions. So I've got the reference down here, but essentially 1 in every 72 patients delayed a bed transfer beyond 8 hours adds to 30-day all-cause mortality. Then we've got the third harm. The third harm, that would be patients entering the ED. So many of you are here because you might have some ambulances ramped at your front door. And we know that harm results due to this delay. And we know this because the AACE has done some audit work, and they have told us that 9% of patients delayed being offloaded beyond 60 minutes from arrival at ED come to severe harm. And severe harm will include mortality as well, but it will also include a degree of rapid deconditioning as a result of the stretchers and so which they're on. And then there's undoubtedly harm in the community for patients waiting for ambulances, waiting to access 111 and not being able to get through. Now, these are all connected, which is really, really important. So perhaps you've already noticed, but we can see over time. So I haven't told you where this data is from. And unfortunately, because it's an open presentation, I'm not going to tell you where it is from, but it is from a region in the across England. To be honest, I could have picked any region and the data would have pretty much looked the same. So we are moving from September last year all the way to where we are now. And we can see these trends. So CAT2 response time, we've got our total handover time lost for EDs, we've got our patients waiting over 12 hours at ED, and we've got our non-elective stay. And we can see that the patterns of these are very similar. And the reason for it is that these are fairly much related. Got delay in patients moving out of the hospital, I'm going to have delays in patients moving out of ED. I'm going to have delays in patients moving into ED, and I'm going to have delays in the community. The problem is because this part of the system functions in minutes to hours, and this part of the system functions in days to weeks, you only need small changes here in order to invoke big changes here. And we're going to come back to this. I've got some additional slides and so, but it's really important to understand as we move through the system, the problem compounds and gets more complex. Now, as I said, we can define harm here to an extent. It is a calculated value. It's reported on your GIRFT report, and you'll also see it in your ECIST reports if you get those. And then this is also a calculated number. I don't think this is reported in any reports, but if you follow this link, once you get the slides, you'll be able to see the document where I've pulled it from. We've got no idea what the harm is that we see in the community, but we know that this must be a fairly large number. All right, so okay, so you probably noticed that this line doesn't quite look like this line. Now I'm going to go into that just in a little bit of detail. That's because our non-elective length of stay is really made up of 2 things. It's our patients that are not staying in the hospital for a very long time, so they bounce out of hospital really, really quickly. And then we've got our patients that are here for a much, much longer time. Now, in general, these two as a combination makes up what we see as a non-elective length of stay. So if I've got a high proportion of patients that leaves on 0 day, it means my non-elective length of stay will be brought down because this is an average number. If I've got a lot of patients proportionally that stay a long time, it's going to affect my non-elective length of stay. So that's why this doesn't necessarily look exactly like this. But when we look at this model and we look at our 21-day length of stay, we can see that this kind of follows that model a little bit more. Now, I don't want you to get too distracted too much about this. Depending on the system you look at, it could be any of these two or both of these that contributes to what we see here. And I'm going to come back to variation, but there is a huge amount of variation which we see in our system. What I'm showing you here are mean numbers. And unfortunately, for anybody who works in urgent and emergency care, we know that nothing keeps on the mean. There is an incredible amount of variation. Now, I just want to point this out early because we're going to come back to this later on in the presentation. But when we talk about patients staying in hospital for a short period of time, the reason we are able to shift these patients really, really quickly through the system is mainly because of specialty response. And when we have patients that staying in the hospitals for a really, really long time, specialty response is much lower here. Usually a decision has already been made that this patient is fit to no longer be in hospital, and this is more of an operational response. So it's really important to understand that these two things are at opposite ends of the spectrum, where on one side of the spectrum we've got more requirement for specialty response, and on the other side a higher requirement for operational response. Sorry. Okay, so as I said, if we're going to talk about ED, we need to talk about, if we're going to talk about UEC, we're going to start with ED because that's where we have the most data. So what is the problem in ED? Why are EDs so congested? So it's really, really simple. So if you go and look at the building guidance, the architectural guidance for emergency departments, you'll find that they've got this fixed number in there. So when we want to design our EDs, we're going to say that, I've got so many patients that attends my department, and this is a proportion of them that's going to be a high priority, needing majors and resus, and that is going to be the proportion that requires my seated area and waiting room. So what the architects then do is they take your number of attendances that's high priority that needs to go to majors and resus, and they do a little calculation with that using this turnover. So turnover of 2 to 3 hours per majors cubicle, majors or resus cubicle. So now the problem is that this may have worked 10 years ago when we were flowing patients through our service. But if we now have a patient that stays in that cubicle for 12 plus hours, it means that there are some patients that cannot use that space. Remember, I said our front door operates in minutes and hours. So if I start pushing using my emergency department in hours and days, it means that some patients cannot access that space. And that simply is why we end up with patients in our non-designated area. So it might be a corridor bay, or a patient in a cupboard somewhere, or patients out on the ambulance ramp. So we can look at this in a little bit more detail. So we're going to start on this slide first, and I'm just going to explain to you what you're looking at. But essentially, this is arrivals into an emergency department. This is an average emergency department. Again, I cannot tell you where this is from, but this is over the 24-hour period. And most emergency departments will have the same kind of distribution. So patient starts coming in from around 8 o'clock, and then we have this peak walk-in arrival between 9 and 9, and then it goes down again. And then between midnight and 8 o'clock, we've got low attendances. We can lay our ambulances over it. So in general, ambulances tend to peak slightly later than our walk-ins, about an hour later, so from 10 to 10. And then what I can do is I can add on occupancy. So occupancy is related to arrivals, but it's also related to who is already in the department. So if I see every patient, I have the ability to see every patient on the hour that they arrive, then occupancy would be exactly the same as my arrivals. But because I cannot process every patient within an hour of arrival, it means that when I get to the next hour, I've got the patients from the previous hour that hasn't been sorted out that's in the department. Now, in general, we see this peak occupancy starting around 9 o'clock, so exactly when we see our walk-in starting, so occupancy starts going up, and then it stays up, and it stays up a lot later, and that's usually related to how long it takes for your department to process patients. And in general, we'll see that occupancy is around 30% higher than our arrivals. It can be much higher in our services that are a lot more pressured, but on average, it's around 30% higher than what we'll see with arrivals. Now, this is very tricky because when we talk about what is in our departments at the moment, most often we don't know. What we know is that we've got a non-admitted cohort, so we've got a group of patients going home, and then we've got an admitted cohort, which is a group of patients that needs to come into hospital. Now, again, in general, when we talk about admissions, we know that about 2/3 of patients wait more than 4 hours to be admitted, and about 20% wait more than 12 hours. And this will vary across the year, but in general, this is kind of what we see. When we talk about non-admitted, it's around a 2/3 of patients that goes home within 4 hours. But we don't know who these patients belong to. We don't know, is it ED who made a delayed decision to make a referral? Is this the specialty teams that are taking a really long time? Are this operational teams that really make taking long to allocate beds? So we really don't know because we don't collect that data in a robust way. So in a simplified way, when we look at what's coming in through ED, it is really important, and I'm going to come back to this further down the slides, but it's really important for us to be able to differentiate. So we know exactly when patients are coming into our ED. We know exactly when ED is making a discharge for those patients. We know when referrals happens in most EDs. I've got ready to proceed in there, which you can ignore for the moment, but we can come back to that if there's questions. But essentially, referral happens. And then we know that specialties gets involved. They see patients, they either discharge and they admit. So this makes up our non-admitted cohort. This makes up our admitted cohort. And we can collect some of the data around here. So as I said, ED is measured to death. So we actually know exactly what's going on here. And then we've kind of got this bit of a black hole which happened after referral. And then a decision to admit a decision is made. And then we know again what's going on. But we have this space within our service where we don't actually know a lot that is going on. Now, I've linked 3 teams in here because I call it the 3-team model. But in essence, when we look at ED, there are three cohorts operating in ED. It's emergency medicine, which is right at the front. And then we've got specialties, which we hand over patients to, and then specialties hand over to operations. And these are the 3 groups that we have. We know a lot about what's going on here. We know hardly anything that's going on here. And then we know a bit about what's going on there. And you can see it becomes really, really problematic because when we talk about, and this is a different slide from the one I showed you before, so that end slide that was here is now here, we've got this unresolved caseload, which we don't really know what it's made up of. Now, it's quite often made up of our admitted and non-admitted cohort, but it's really important that we are able to define this. And I'm going to show you why. So these 2 slides are modeled slides. What we did on this slide is we modeled this unresolved caseload, and we said that if we make admitted time, so that long admitted time which I showed you, we made it exactly the same as non-admitted time. So those 2/3 of patients that are admitted after 4 hours, we make it that they are all admitted within the first 4 hours. We can actually reduce occupancy by around 12%. All right. Now, in general, and you can go and look at the database, a rule of thumb, most departments, non-admitted time will be about half your admitted time. So if you got a mean admitted time of around 6 hours, your non-admitted time would probably be around 3 hours, probably just a little bit below. So it's kind of reducing what I have in my service by about half, drops my occupancy. Now, interestingly, if I say that not a single patient in my department stays beyond 4 hours, I can have a dramatic reduction in my occupancy. Now, what does this do in our departments? Our emergency departments will probably have an increase in space. Increase in space means that we've got improved productivity, and improved productivity gives us quality and safety. Now, although this may look like an impossible ask, I'll remind you that up until 2014, we were making a 95% adherence to the 4-hour target in most of our emergency departments across the nation. So this is where we are now. This is where we are a decade ago. And you can see the challenge we are having within our departments. Now, sorry about that. Now, the problem that we see in ED is basically replicated throughout the system. So, and this is why it's important to have an understanding of more than just the system. I gave you the view of what I see as an emergency physician when I walk into my emergency department, but the acute physicians amongst you will give perhaps this perspective. So the Society of Acute Medicine tells us that the ideal turnover on a medical assessment unit is probably between 12, 24 hours. So the problem is, if I got a patient in such a space for more than 48 hours or up to a week or so, it means that that space is not accessible for the patients that need to be flowing into there from our urgent and emergency care areas, such as ED, virtual wards, step downs, and so on. And it means that those patients then just flow back into the ED. It causes congestion there, and then we end up with patients being placed in non-designated spaces. So the whole thing is connected up. And unless we are able to see the entire service for what it is, it will not be possible for us to make any differences. So what I'm going to do now is I'm going to have a brief pause. So if anybody wants to just, going to give 30 seconds if you want to stand up and stretch your legs in case it starts cramping. And then I'm going to motor on. So what I have done whilst you're stretching your legs, I've kind of given you the challenges and how we are looking at urgent and emergency care. Okay, finish stretching legs. So what I'm going to do next is I'm going to talk a little bit more about how we are to overcome this challenge. Now, for me, as somebody with a background in data and data translation, so I am naturally going to talk to you about data. And I'm going to talk to you about data in the way we have developed this in the Southwest. At the end of this talk, I've got some QR codes. And if you are linked in on NHS Futures, you will be able to access these. If you don't have access to NHS Futures, unfortunately, we cannot make this available to you. So let's talk about the data. Now, when I started with my UEC job, one of the first challenges I ran into is that there were a lot of well-meaning people working in urgent and emergency care who didn't have a good understanding of the data that underpinned how flow worked through the entire service. And we came up with this model to kind of define at what level we need to keep our data to keep it understandable and to keep people on message. And we said that if we use Lego as an analogy, we need to try and keep our data at a Duplo level. So Duplo level, that would be basic, intuitive, very simple to interpret data, our 4-hour target, our 12-hour target, our CAT2 response time. For some things, we need to have a little bit more detail, and then we can have very detailed information we can provide, but we should really keep this incredibly simple. And for the most part, we should really be focusing, when we talk about data, when we're doing our presentations, is keeping it here. Now, I can guarantee you that most of you would have sat through some system presentation. So I've sat through these myself where I don't understand half the data that's being presented to me. Now, I'm very switched on with data. So if I can't understand it, I can guarantee you that a large portion of stakeholders that are listening to that talk is also not engaging with that. So if we want to use data to help us to improve, we need to keep it really, really simple. And if we don't keep it really, really simple, we will lose people. And if we lose people, unfortunately, they are not going to be able to help us with improvement. So this is the first point. So when we use data, we need to keep it really, really simple. Now, the problem is with keeping data really, really simple in urgent and emergency care is emergency care or urgent and emergency care isn't simple. You know, I started off by showing you a slide with 4 data pieces which come from 4 different parts of the system. And each of these are underpinned by more data and so it can become really complex really, really quickly. You know, in addition to that, we need to be able to see across the entire pathway. Some of the data points we actually need to be able to process in real time, and other data points we would rather see on a weekly or a monthly basis. And if we don't plug the right data into the right areas, it means that we're going to end up confusing ourselves and following the rabbit down the rabbit hole, which so quite often happens. I'm going to show you a few examples just with how we, some of our sites in the Southwest has dealt with this problem, and also what we have done in the Southwest to kind of make data a little bit more accessible and a little bit more Duplo-like. Okay, so when we talk about real-time drivers, remember I said to you that we need to be able to find better what is happening in our system. I need to be able, when I look at my ED data, so my ED data in real time, I should be able to see what emergency medicine is doing, and I should also be able to see what specialties and our operational teams are doing. So this is a dashboard, and I've anonymized it as much as I can. So it is a little bit of a mess, and I know the team is busy doing some cleaning up, but I'm going to point a few things out for you, which they have done. So up here on the right, you can see the 4-hour performance for this service, and you can see it's sitting at 76%. So this is taken from yesterday. But here it's got another disposition, which is sitting at 90%. So what they have done here is they've essentially framed the volume that's come through the emergency department to only the timings which was applied by emergency medicine. So they removed specialties completely from it. So at a stroke, you can see that actually in this service, emergency medicine are actually doing really, really well. You know, they are moving 90% of their caseload within 4 hours. And this is coming from somewhere else. So this drop is coming from somewhere else. So going a little bit further, we can see that they have recorded time to EM clinician and also time to EM disposition. So we can see that their EM disposition is sitting around 140 minutes here. And then they actually break it up. So they have got average time to referral, which is at around 160 minutes, which is under 3 hours. And then time for EM to make a discharge, so emergency medicine secretary. So really taking emergency medicine and separating it out so that we can look at that separately. And then right next to here, what they have is they've got the referral. So we're looking at referral and looking at the various specialty teams as referrals are made. And you can see the average waiting times for each of these. And we can also see the average time to admission and average time to non-admission. And you can see there's variation, for instance, medicine, and you'll recognize this as well in your own teams. But the average time at admission is taking really, really long, whereas for surgery, it's a lot shorter. So this means if we want to have a conversation around this, we can specifically look at the long time to admissions for medicine, have a conversation with our operational teams to kind of have an understanding about why this is long. But for surgery, we may not necessarily have to have the same conversation, nor for pediatrics. So it allows us to drill down a lot deeper and give us a differentiation of what is going on. So just to point out, so they've got this lovely escalation box, which I love. But you can see it's showing that one ambulance is waiting to offload. So when I look at this data to give context to it, I'll probably say that this ambulance is not being offloaded, probably not because of what's going on with an EM as a specialty, but probably more as to what's going on with flow following referral, so within the specialty and operations. But it gives us a really good real-time perspective with a dashboard that updates about data, which is useful in the moment for us to make some real-time changes. All right, so that's real-time. So longer term drivers is really, really difficult. And it took us about 6 months, and we actually made a recent update to it as well, to kind of create a Duplo-ish dashboard that could help our ICBs, our trusts and sites in the Southwest to have a better understanding of where the problems in their data lies. So when we look at moving from A&E, so into the hospital, we can define 4 different things. So you can define lots. I define 4 things because it helped me to think about it in a particular way. But there's input, which is patients coming into the service, throughput, which is patients moving through the service, and then output, which is patients moving out of the service. And this tends to be the direction of patient travel. More recently, we also have maturity of certain services that kind of plugs in at various levels here, such as SDEC, frailty, virtual ward, urgent community response, and so, which has an impact on how these things work. I've defined a few things here. So for input, conversion rates, conversion growth, beds per population. We know that some of our sites has actually got a very, very low bed base per population compared to other sites got a very high number of bed population, not very high, but a higher number of bed populations. I've already mentioned throughput, our non-elective length of stay, which is really a balance between early movers and late movers. And then outputs, no doubt thinking about discharge and pre-midday, pre-5 o'clock, and then weekend discharge. But all of this is, again, it's a lot of information. So if I just kind of list this, it's going to cause a lot of confusion. So how do I put this information in a format that really, really helps? And I'm so sorry, the next slide is going to shock you. No, it's not. So it's just to point out that when we get congestion, because these services, unlike ED, don't have or tend to not have capacity to store patients, they tend to be stored in A&E, usually on our ambulance ramps in the corridors in ED. Some services have ways in which they can make use of corridors and spaces on wards as well. For the vast majority don't. So there's much less capacity or stretch in once a patient crosses into the hospital when you have congestion to manage that additional caseload. Okay, so now we're going to come to the slide that shocks you. Okay, so busy slide. So I'm going to break it down for you because it is less busy than you think. Again, I have anonymized it. We're going to have a link to this. If you've got access to NHS Futures, you should be able to access this and go and look at what we have done here. But essentially what we did is we used the 4 harms. So use a Duplo model to define over time and in reference, and I'm going to come to this in a bit more detail, and in reference to our to the region, how a site is doing. And it's not just a site, so use a box here which you can click, and then you can look down at an ICB level, a trust level, or a site level where there are multiple sites within a trust. So what we have is, so just 4 harms again, but obviously we've got our organizational flow harm when patients can't move out of a service. We've got the harm from patients that needs to exit ED, the harm from patients needs to enter ED, and then the harm in the community. Now, what you can see on here is for the specific site is time. So we've got the last 12 months and then the most current month here in blue with a little bit of a trend table there. And then on the side here, we can compare each of these metrics that we have to the regional mean, which kind of gives us an idea of the problem. Now, I'm going to show you in a second how this plays out in 4 different sites. But if we look at this, we can see there's a lot of amber and yellow in this area and a lot of amber and red here, but this is more green. So we probably say that this trust probably struggles with harm 3 and harm 4, and it allows us to target those areas very specifically. So what are the data points that we have chosen? So again, we came together as a UEC team and we had lots of discussions about what we are going to include and what we are not going to include. So for harm 4, we've got bed occupancy. We're using no criteria to reside for our occupied beds. We're also using no criteria to reside for our pathway 0 discharge. So it's fascinating having a pathway where patients literally just need to put their shoes on and leave, how tricky it is for some trusts to shift those patients out. Non-elective length of stay, as you know, I'm a big fan. And then our over 21-day length of stay. We've got our discharges linked in there. And then we've kind of borrowed a little bit from ECUS with their permission, but using our non-elective 0-day length of stay, and then something called a non-elective opportunity. And we link this back to our same-day emergency care, but essentially non-elective opportunity is if I take all my patients who has stayed in my hospital under 2 days, and I subtract the number of patients that has left the hospital on 0 day. I call this an opportunity. It's an opportunity. If a patient's only going to stay under 2 days, do they need to stay at all? And there is an opportunity there. Then for frailty, what we do is we have exactly the same, but we just limit it to patients over 75. So I've got some really pertinent data which tells me about harm 4. It tells me about how patients flow through the system. So for harm 3, looking specifically at ED exit, so we're using the 4-hour target, but we're using type 1 target. So you can have all types, and we do have it here. It's right here at the bottom, but that's when we have our type 3 data mixed in there. Your type 3 data is your minus data. We're saying that A&Es are really, really about what is severe and bad. So this is how we need to move patients through. We've got our 12 hours there. We've got our mean admitted, mean non-admitted, patients staying over that's older than 75, and our mental health cohort. Got ready to proceed in there. I must say, ready to proceed has been a bit of a disappointing metric, but we've got it in there as well. Coming down to entering the ED, we've got the proportion of patients which is assessed within 15 minutes. So this is triage within 15 minutes. And then we've broken it down and looked only at ambulance arrivals, because we say, well, if you've got an ambulance ramped on your front door, is this patient assessed at least in a timely way before we move them back onto the ambulance? So we can track that as well. And then we've got the standard bits about a number of ambulance attendances, our total time lost, and handovers. When we look at the community, we've got our walk-ins, 111s, and 909 cohort, and we are about to add also virtual ward capacity, our urgent care, urgent community response, and urgent community response capacity. So in a whole, what we'll have is we'll have a system that can show us very, very simply where a problem lies. And this varies. I'm going to show you a different trust. So this one has got a big problem with their harm 4, and here's another one. So you can see where the harm is, and it's very simple to see that. And then we can go and dig down. We can look at this data, and if we want to, we can go into the Technic data and look at that in a bit more detail as well. Okay, so now we're in for the home stretch, and I think I've got about 7 or 8 minutes before we get there. I think I'm just going to push on. But if you want to stand up and stretch, we can do that now. Now, the last bit that I'm going to talk about is around engaging effectively with our specialty services. Now, in my mind, when I see urgent emergency care flow beyond emergency medicine, I see there are 3 big movers which can move services, patients through our services. The first one is SDEC, and if you haven't engaged with SDEC yet, you should, because it is definitely a big mover. The second one is our operational prowess. So how well is your operations team functioning within your hospital? And the third one is our specialty engagement. Now, I'm really sad to say, as a specialist myself, that we tend to be the weakest of the 3. So how do we deal with this? So the way we've gone about in the Southwest is we have decided we're going to link this to trust values. So trust values are defined for every single trust. Most NHSE organizations, including the regional teams and ICBs, and so will have trust values that are defined. And usually if we do thematic analysis, it'll thematically link to about 4 things, which is patient-centered approach, respect for each other and our patients, teamwork, and leading to improvement. Now, this is all very nice, and you can see the nice pictures and stuff. I've taken some the liberty of copying this from the internet from some trusts across the nation. Now, when I layer this over what we see in our EDs, it becomes really, really difficult to associate our trust values with some of the challenges that we have. Now, I know this is very difficult for us to look at. It's certainly as difficult for me every day when I come into my department and there's 3 or 4 ambulances ramped outside. But this is the reality where we are. And in a way, we need to move more towards where our trust values are. And we found that actually using our trust values, so trust values, what matters most to an organization, our trust values already present us with a framework that can define how we want to interact with our patients. So like I put down on the slide, organizational identity, our culture, our decisions, our actions and behaviors. Now, if that's what our trust values does, we can use it to contextualize into professional standards. Professional standards, we all talk about that. Some of us hate it, but really being able to work together through disciplines and also specialties is key to moving urgent and emergency care. So how do we do that? So what we propose, and actually we don't just propose this, there's NHS national documents that proposes this as well, is moving from a patient-centered, moving from our trust values with executive leadership through focus groups to create durable professional standards, which we can express visibly on our public websites through induction, with real-time data tracking and governance and improvement. Now, we use a tool which we created in the Southwest, so we spend an enormous amount of time with our various sites and services in urgent emergency care, and we are specialists, nurses, operational leads, and so to tell us what are the important things that should be included in professional standards. And we came up with what you see here in the back, and I'm going to show it to you in large now, what we call the Unified Care Framework. Now, there's going to be a link to this at the end. You should be able to scan that. But there are 10 parts which this thematic analysis came up with that every internal professional standard or value should include. Now, the Unified Care Framework is a guide to professional standards or professional values, which is actually the word I prefer. It is not professional standards in itself. And if you take a bit more time after we're done here to read through this, you'll see that it provides a guidance to get there. Now, and this leads me to almost finishing now, but there are 2 of the standards that's come up in green. Now, the reason these 2 are coming up in green is because these were the most challenging for us to reach agreement with when we did the thematic work on this. And this comes back, unfortunately, to specialty engagement. So the first one is around clinical ownership following an acute referral. So I make a referral to a specialty team, or the acute physician makes a referral to another specialty team. And there's this conundrum between clinical ownership. When is the patient mine? When is the patient yours? Is the patient mine if the patient's still in ED or on SDEC or on AMU, or when does this happen? Now, this is something that we can have a conversation about, and we can work this out in our organizations. And I think this is critical to do if we want to improve that blurry bit of timeline, which I've shown you on our timelines through EDs and SDECs and AMUs. And then the second one is a timely assessment. We don't agree what a timely assessment is. And I understand this. My world, we work in minutes and hours. So when I make a referral, my expectation is a response within minutes and hours. But if your world is a service which functions in hours to days, then acute referral, your expectation might be that you expect a response within hours to days. And this variation that we see here becomes problematic. And unless we can resolve this in our organizations, we will struggle to move beyond these. I would say if you set up internal professional standards and you don't have time to focus on all of them, if you focus on only agreeing two things that you should first agree, clinical ownership, transfer following a referral, and what is meant with a timely assessment following an acute referral. So just in summary, so I may not have given you very specific stuff for your organization. So this will be very deliberate because there is a huge amount of variation. UEC flow is complex, and it's impossible to compare one site to the other site just because of their variation between them. We know harm is happening. It's happening all the time. But because it's delayed, we can only measure it 30 days later. It tends to be de-emphasized operationally. But really, when we talk about harm, that's probably what is important to patients. I want to know I'm going to be able to safely process through the acute hospital system. And unfortunately, at the moment, we know that some patients don't. So patients level outcomes are really, really important. And this is what we should use to focus any of the improvement that we are doing. Data can be really complex. And as I said on there, we can get really, really lost in it. But we can keep it simple. And if it's difficult to keep it simple, we can connect it to simple patient level narratives. So the narrative around the 4 harms is a really, really good way to do that. And in the Southwest, I know there are many of the sites that use our spreadsheet specifically because it gives this really simple connection. Internal professional values are incredibly important to your trust. It's also incredibly difficult to set up. And when you are going to set it up, you need to anticipate that there will be challenges with the specialty teams. And that's really the long and the short. So there's some links here. You'll be able to look at this yourself when the slides are sent to you. But as I said, this links to NHS Futures. And unfortunately, if you don't have access to NHS Futures, I wouldn't be able to share this with you. And that brings us to the Q&A. And I believe I am meant to unshare my slides.
So we have a question in the chat box. So it's, do you have any insights that may help patient flow through GP-led / ANP-led urgent treatment centres?
So what I know from the type 3 data is that most organizations, so type 3 data would be usually the data that goes through our acute, our urgent treatment centres. And what I know is that most trusts, actually we saw that during the Hunger Games back in March as well, when there were money put out for services to improve their 4-hour targets. What a lot of organizations did is they actually push the type 3 activity to improve within the organizations because they were able to offset weaker type 1 data through there. So yes, it's a really important question. How do we help patient flow through GP-led or ANP-led urgent treatment centers? My belief is that it should work exactly the same as ED. In fact, I think one of the problems with the data sets that we are using is that we are constantly creating new variables when we can actually just apply the same variables across the entire system. So in ED, we measure time to triage, we measure time to first clinician, we measure time to treatment, and we need measure time to disposition. Now we can measure the same things within the urgent treatment center. We can measure the same things within our AMU. We can measure the same things in our SDEC. And what this does, it means that if I'm an operational person with oversight ICB level, and so I can see it all the same, and I don't need to learn what each of these metrics mean because I already know what it means because it is the same no matter where I look. So what I would probably say is if you want to have an understanding of patient flow through our urgent treatment centers, we just need to use the same basic metrics that we are using and applying in ED, but extending that as well, as we should be measuring the same when we look at our SDEX, and we should probably be measuring the same when we're looking at our AMUs. And I think that will give us really, really valid data to help understand how our patients move through a system. So I hope that answers the question.
Thank you. If anyone has any other questions, please feel free to put them in the question and answer box. So I do have an anonymous question, which is, what are your recommendations for avoiding inappropriate ED attendances?
So I think that's really difficult to define. What is inappropriate? I think if we take a patient perspective, most patients would believe that their attendance is, even if they attend with what I believe is inappropriate, patients will believe that their attendance is appropriate. Now, I think we can't really talk about what we would refer to as inappropriate attendances without referring to a system under pressure. I think if our primary care has got better capacity, that we will probably see less of this. It's not well understood quite often that primary care or the community deals with around 95% of all patient contacts on a day. So only 5% is really what we see coming through our acute sites. So having a variation of only 1 or 2 or 3% within that community primary care setup will cause big disruption with what we see in acute care. We see 5% and suddenly we see 6%, you're almost certainly going to see inappropriate patients. I will say at the same time that inappropriate patients are not just coming from primary care. So if you get the ECAS data set, they actually record the proportion of patients that attend to your emergency department that's on a waiting list somewhere. So we know that delayed waiting list is also causing attendances coming to ED. We also know that we're diagnosing more cancers and so in ED. So these are all patients that traditionally would have gone elsewhere and had their diagnosis, or they would have had their care much sooner, which means that they didn't have to access emergency care. So it is really, really a complex problem. But I think it's difficult. If we are going to redirect patients elsewhere, we need to have services that are available to redirect them. But I think this is where the complexity comes in, redirecting back to GP when GP is already at capacity. It's kind of the same when people direct patients to ED and ED is already at capacity. So we're kind of just spreading the problem around. So I hope that sort of answers your question. I think it's a really complex problem. And I was really glad to see that the Health Secretary has specifically said that they want to improve capacity in primary care. As somebody who's working global health, I can guarantee you that will probably have the biggest impact on urgent and emergency care. Any of our interventions that we do would pale in comparison to just improving preventative and primary care.
Okay, thank you. Also had another question sent privately. How did you specifically look at in regards to streamlining at frailty through the front door?
Yes, so frailty is even trickier. So just looking at how much time I have. So frailty is not quite the same as our medical SDEX. So our SDEX, the largest cohort that goes through SDEX are medicine. And yes, we've got peds and gynae and surgeons or so, but those numbers are much, much smaller than the medical patients coming through. Now, frailty is layered across that. So we will have a portion of our patients coming into the medical SDEC and a portion of our patients coming into our EDs, which have got a frailty problem. Now, the whole frailty setup is not working so well in most units. And there's a variety of reasons for this. So one of the things that I've linked to in one of my QR codes is the maturity indices so this was put out last year by the national UEC team, and if you actually just go and Google NHSE UEC maturity indices, you'll get that. And there's a maturity index specifically for acute frailty. Now, when we go out on visits to sites and specifically look at the frailty often, so what we find is that most services are not mature in how they provide service, and this reaches across the spectrum. So clinical frailty is not identified early. Now, the problem is if we want to redirect and stream, we actually need to be able to identify problems really, really soon. So if we are not picking up a clinical frailty really early, our teams from across the hospital, because this tends to be the most popular model, is this in-reach or almost like a frailty flying squad kind of team that goes to SDEC and EDs to kind of respond. They wouldn't be able to pick this up, and we'll only pick it up in 2 hours time when the doctor's eventually seen it and maybe have added that on, or the team has to do that themselves. So there's a problem there, but there's also a problem that we don't necessarily have adequate teams that deals with this. So we know that the ACP or the advanced practitioner model works really well in frailty. Also, we know that many of these teams aren't really well connected up to virtual ward. Many of these patients lean themselves towards management within a hospital at home or a virtual environment. So there are multiple issues which lacks within various services. My recommendation, if you want to evaluate where your frailty service is and you want to do it just really, really quickly, just go and look at how many of the 8 points which is listed on the maturity index for acute frailty your service achieves, and you'll probably find it's less than half, but those will be the things that you need to focus on.
Perfect, thank you. We've had more of a statement in the chat box. So it says, rather than the inappropriate patient, we need to get the patient to the right place, the right time, the first time. So Neuro/PPA models are vital.
So this links in with I couldn't agree with that more, but I will say the caveat on that is that we don't necessarily agree on where the right place and the right time is between various teams, and this goes from primary care all the way through to emergency medicine and specialty teams. And this is why internal professional standard values are so important. We should be able to agree where patients go, and actually sites do a fantastic job of that. So one of the sites, one of the trusts that I look after, has actually painstakingly written a whole A4 of these patients that we tend to struggle with, the backaches and the head injuries and the elderly, and who should be looking after this patient, where should this patient be diverted to when they come through. So you can do this, but it takes time, and it it really needs to be led from an executive level.
Mm-hmm. So
yeah, which specialty document? Yeah, I see that. Yeah, exactly. Yeah.
So yeah, I'd like to just say thank you so much to Stevan for delivering such an interesting and insightful webinar. I hope everyone found it very useful. I'd also like to say thank you to all of you for taking part in today's webinar.